everyone, and welcome to today's webinar on the Wellbeing Index and how to reveal burnout in just 9 questions. We're so happy that you all could join us as we dig into the functionalities of the Wellbeing Index and discuss how institutions across the country and across the world use it to assess the wellness of their organizations. My name is Patrick McNally. I'm an account strategist at MedEd Web Solutions. I'll be moderating today's webinar and fielding any questions or comments you have about the Wellbeing Index. As we get into the presentation, we encourage questions, so please take a moment, use the Q&A feature at the bottom of your screen, and a new window will open up where you can ask questions and see the answers. Just a few reminders: you will be receiving a recording of today's webinar via email following the presentation, and will receive contact information for any follow-up questions you have. We also encourage you to go to mededwebs.com/wellbeing-index and try the Wellbeing Index demo for yourself. All right, I think it's time to get started. I'd like to introduce today's presenter, Sunny Prabhakar. Sunny is also an account strategist at MedEd Web Solutions and has been vital to helping organizations understand and use the Wellbeing Index to assess burnout at their institutions. Sunny, take it away.
Thank you, Patrick. I really appreciate that wonderful introduction. And as I've worked with numerous hospitals and universities across the country, the best part of my day is hearing the stories of organizations who have been able to tangibly move the needle on the well-being of their staff. Burnout's a real issue in the healthcare industry. It's no secret. So it's encouraging to see so many of you on this call today. I appreciate you taking the time out of your day to learn more about the Wellbeing Index, and I welcome any questions that you may have. So today, we're going to look at who is MedEd Web Solutions, the physician burnout problem, a demonstration of the Wellbeing Index live, and then how you guys can get involved. But before we begin, I'd like to disclose that much of what I'll be sharing with you today is based on the research and findings of Dr. Shanafelt and Dr. Derby from the Mayo Clinic. They are the inventors of the Wellbeing Index and have dedicated many, many years of their careers bringing the Wellbeing Index to life. And I'm going to share with you a story of how it came into fruition in a little bit, but in the meantime, just know I may appear smarter than I actually am. So a common question that I'm always asked is, who's actually behind the Wellbeing Index? As you know, the Mayo Clinic developed a tool for their own internal purposes initially, but a couple years later, they had so much interest that Mayo Clinic decided to license the index to MedEd Web Solutions. We are the web and application development company that worked with Dr. Derby and Dr. Shanafelt on the first version of the Wellbeing Index back in 2014. We're based in Rochester, Minnesota, right next door to the Mayo Clinic. And for the last 10 years, we have worked extensively with departments throughout Mayo Clinic on various web-based projects and initiatives. We also have an office in Phoenix and continue to work with healthcare companies all across the United States and now globally through the Wellbeing Index. So let's begin by talking a little bit about why we're here today. There's challenges of emotional health and burnout. Majority of physicians believe that their workload is too heavy. Over half believe that their family and personal lives suffer because they are a physician. And only about a third believe that their work schedule leaves enough time for the personal or for the family time at home. And that's how burnout is affecting many of our healthcare workers. It's crazy to understand how these physicians are helping others while still dealing with all of these other issues internally in the hospital and also externally at home. So part of this could be due to the nature of the actual physician work environment. It's often a hostile work environment with excessive demands on time, a chaotic pace, limited control over input variables, and a feeling of isolation. A lot of times physicians are made to feel that it's a you problem, it's a personal problem, but in reality, it's honestly a systemic or a cultural problem that they're dealing with. This and other factors, which I'll discuss shortly, have led us all to know the term burnout. But what does that really mean? Well, burnout is a symptom of depersonalization, emotional exhaustion, and low personal accomplishment that leads to decreased effectiveness at work. So if we look at that a bit closer, we can see that depersonalization is beginning to treat individuals like objects. Emotional exhaustion is losing enthusiasm for the work that you're doing. And low personal accomplishment is essentially losing a sense that your work has meaning, or feeling effective in your work. Now, we also know that burnout among physicians is much higher than other U.S. workers. So it's not just a problem in the U.S. across all industries. In a 2017 study of the general population versus physicians, it showed a 41% burnout rate for physicians, compared to a 28% burnout rate for U.S. workers. We also learned that from 2014 to 2017, that number decreased just slightly, for physicians, and decreased greatly for the U.S. population. So that we can see that while the physicians' burnout is, decreasing slightly, or we're improving well-being a little bit, physicians are still way more at risk for burnout in comparison to the general population, which is a scary thought because these are the people who are helping us live healthier, happier, longer lives. So here on this chart, you can see the comparison of physicians versus the general population in terms of comparing their burnout and their work-life integration. There's a stark difference between how our physicians are feeling in comparison to U.S. workers. Additionally, and this is the craziest, we're seeing that before students enter medical school and before physicians start beginning their actual practice, their overall well-being is higher than the U.S. population. But as soon as they get into those institutions, or as soon as they get into the medical schools, they fall dramatically below the average U.S. worker. We also know that the burnout rate among physicians is going to vary widely depending on their specialty. National studies are suggesting that 40% of U.S. physicians are experiencing burnout, but as you can see from this chart, the rate among emergency medicine physicians is well over 50%. But the burnout rate among occupational medicine, probably closer to around 30%. So it's going to vary greatly between specialty and oftentimes between departments and locations and culture and all those kind of different factors that go into it. In simple terms, Dr. Shanafelt has categorized the drivers of burnout into 5 dimensions. So these are workload, efficiency of work, physician autonomy and flexibility, work-life integration, and their sense of meaning in work. To make matters worse, the 5 dimensions are compounded by other external factors, like personal factors, the family, what's happening at home, work group factors, hospital, institutional factors, and national factors like national healthcare policy. We know that burnout has professional consequences for the physician and for the institution, such as a reduction in patient satisfaction, a decrease in professionalism. They may reduce their hours or seek other professional roles. And burnout is also associated with an increase in medical errors. In a study of U.S. surgeons, 9% self-reported they had made a major medical error in the last 3 months. We also know that medical errors lead to additional distress. Additional distress leads to increase in medical errors, and the cycle continues on and on and on. But along with professional consequences, we also have personal consequences of burnout, such as increased cynicism, a loss of commitment, a loss of meaning in work, and an increase in suicidal ideation. In a study of U.S. surgeons, 6.4% had thought of suicide in the last 12 months. Now, that might not seem like a huge percentage number, right? But that's 1 out of every 15 surgeons. To make matters worse, only 26% of physicians will actually seek help compared to the U.S. population, which is much higher at around 40%. And this is probably due to the fear of losing your license, feelings like that they're not the ones supposed to be asking for help, or they're not the ones that are supposed to be sick. And this may not be mentioned, but obviously depression is the strongest variable in correlation to suicidal thoughts. So as you can imagine, when Dr. Shanafelt and Dr. Derby were studying this problem almost 8 years ago, they wanted to help Mayo Clinic reduce burnout and increase engagement. There were tools available such as the Mazak burnout inventory, surveys on suicide, depression, etc. But as you know, physicians are already over-surveyed. They figured if we could just take a qualifying question from each survey, we'd have a relevant tool to predict overall distress. Essentially, if you take the best question from each survey, the one that the majority of people who answered this question this way were depressed or suicidal, and turn them into a yes-no question. So the Wellbeing Index was born as a simple 7 or 9 question survey in an effort to predict risk for distress, track physician well-being over time, and provide access to timely resources. Our goal is to hopefully move them from a pre-contemplation stage to contemplation about their current well-being. Comparing them to their peers is an excellent way, an effective way to do that. And the most important factor is that the well-being index is 100% anonymous and administered by a third party. So, the physicians can answer honestly and truthfully. The first important pillar of the well-being index is the anonymous 7 or 9 simple questions. So this allows the physicians to get immediate feedback on their well-being compared to their peers and the ability to track their well-being over time. Now, it's important to note that the well-being index is not a diagnostic tool. It simply predicts risks towards several dimensions. And these dimensions include fatigue, depression, burnout, anxiety and stress, mental, physical quality of life, and work-life balance. So while there's excellent tools for surveying and predicting just burnout, such as the Maslow Burnout Inventory, we feel like the well-being index does a better job at predicting overall well-being across several dimensions. But most importantly, it's not just a one-time survey. This is a lifelong tool to continue reassessing over time. The second important aspect of the well-being index is what we call just-in-time resources. After we give the participant their well-being score and how they compare nationally and to their peers, they can then access the resources. We have 11 different categories with a video from either Dr. Shanafelt or Dr. Derby on each topic and how it relates to that version. We also have other relevant links to publications, websites, related videos, activities they can do to help improve in that category. It's important to know that those who choose to license the tool, though, you can add your own local resources, such as links to the intranet, PDFs, your EAP phone number, text that gives them more information to also help them with the category that's available to them on campus. Finally, the third pillar to the Wellbeing Index is institutional reports. While the Wellbeing Index is 100% anonymous, we do give those who license the tool access to de-identified aggregate reports as to how their physicians are doing. By default, we provide reports on the percent of physicians with a high level of distress, mean score by gender, specialty, year since graduation, and the resources that have been accessed. We do this to provide feedback right to the institution, hoping they'll use this data to identify their most at-risk groups and implement wellness initiatives. Then, as those programs are implemented, leadership can continue to review mean scores and check outcomes to really track the progress of their efforts to see if it's having an impact. So before I begin our live demo of the Wellbeing Index, I'd like to cover a few key aspects. Those that being that first and foremost, the Wellbeing Index is for the healthcare provider or the healthcare worker. It's the reason that it's 100% anonymous. We want to remove any fear of self-assessing and the implications of not scoring well. If they don't score well, we want to provide them with just-in-time resources to hopefully begin their journey towards improving their well-being. So with that, I'm going to show you the Wellbeing Index in action. And first, I'll show you the experience of the Wellbeing Index from the vantage point of the physician. And then I'm going to show you what the back-end de-identified aggregate reports look like for an institution. As Patrick had mentioned earlier in our presentation, please utilize that Q&A button. I really want to make sure that we provide as much value as possible to you guys and for your time. So you ask those questions, and we'll be sure to tackle each one as well. And I'll pause for questions after the demo too. So let's dive right in. So one thing I wanted to call out here is we do have 6 versions available. I know I focused really pretty heavily on physician statistics, but I want to be mindful of your time. But we do have physicians, medical students, resident fellows, a general healthcare employee version, nurses, and advanced practice providers, which is our NPPA version as well. So 6 different versions, all with national benchmarks, all validated that are available. But today we're going to look primarily at the physician. We'll log into the demo here. Basically, before they get to this screen, which shows them the actual assessment, they're going to go through a quick sign-up process, which is they provide email, a password, they answer a few demographic questions, and then they get right to the survey. Right here, we have a call-out box that tells them how we protect their data, how they can see what sample admin reports look like, and then make sure that they're assured that everything is 100% anonymous when they do this survey. So during the past month, have you felt burned out from your work? Are you worried that your work is hurting you emotionally? Are you feeling down, depressed, or hopeless? Have you fallen asleep while sitting in a public place? Have you felt that all things you do are piling up so high you cannot overcome them? Do you have emotional problems? Has your physical health interfered with the ability to daily work? And then here are the 2 sliding scale questions, 8 and 9. So is your work that you do meaningful to you? And then does your work schedule have enough time for your family and personal life? That's it. Couple minutes, they can answer the survey and then submit the index. Now, if they score lower than 70% of in comparison to the national average, this call-out box will populate. So it has a NAMI helping crisis line, the national suicide hotline, but right here featured in the middle is where you can put your on-campus resource, either the EAP phone number, or it could be a link to book a meeting or a consultation. Whatever you think would be helpful for someone who has scored less than 70% in comparison to the national averages. They can see where their well-being score is in comparison to physicians or residents or medical students or nurses nationally. Also, how do they compare in the organization to their peers? Then we have these awesome moving scales here to show, where are they at on median work, likelihood of burnout, severe fatigue, work-life integration, risk for medical error, and suicidal ideation. And they're able to track their well-being over time after they take the assessment more than once. So they can go back into old assessments, see previous results, see how they scored. And then based on their responses, we're going to show them 4 resource categories that we feel they need the most help in, strictly based on their responses. So if they go in here, they'll see a video, like I said, from Dr. Shannafelt or Dr. Derby. This is where you're able to customize and put local resources in right after the video. And then we'll always have national resources, key publications, and other activities that they can do to help improve in that category. Like we mentioned, there's 11 resource categories here that you can customize and choose from to get help. A lot of people ask too, how do I, how do I get participants to let me know that they took the Wellbeing Index if I wanted to incentivize the Wellbeing Index? So if they go here, they can put in their name, select the date they took the index. You can hit download a certificate, which will create a PDF, or they can email the certificate directly to them. It doesn't show their score, any data, but it's a Wellbeing Index completion transcript with the date that they took it and their name. So now I'll go over to the reporting side. So this is what the admins will see on their dashboard. They're going to see percent of physicians with high levels of distress all time, their mean score compared to the national norm. So overall, how is the institution doing? And then we'll see it broken down by the demographic questions that we ask. So you'll see it broken out by gender, by specialty, by graduation. On these 3 standard demographic questions, we actually have national benchmarks populated as well that you can compare against. You do on our advocate and champion plans, which we'll go through in a little bit. You have the ability to add 3 more custom demographic questions. So if you have multiple locations, or if you wanted to filter based on if they're in your wellness program or not, you could ask those questions and we'll populate additional graphs for you that show that data. In each of these reports, you have some functionality here. So you can see the table of how it was built. You can see the sample size. And so all the information is de-identified aggregate reporting. So like right here, you can see pediatric surgery had only 1 person identify as the pediatric surgeon. So we could not show that data. You need to have at least 5 in the sample size for us to show the data point. You can also do some configuring. So if you want to look at year over year, how are we doing? How are we performing? Are we improving or are we not improving? You can look at first-time assessments, recent assessments, all assessments, and then you'll get a table here broken out showing percent change as well based on that time frame. Going back to the dashboard, in addition to those reports, you also get some engagement reports. You can see how many people have signed up, how many people have assessed versus reassessed, and then also what resources are they accessing. You can actually see which ones are they clicking into, and to get a better idea of like what interventions you should be structuring. So like health behavior is getting 210 people versus fatigue is only getting 178, then maybe we should be looking at delivering more resources internally on health behavior. On our champion plan, you have the ability to add 2 fully customizable process improvement survey questions. These questions pop up as soon as they finish the assessment, and they can be long form questions or they could be multiple choice. So 2 examples would be, if your leadership could do one thing to help improve your well-being in the next 6 months, they can answer that in long form, and you'll get all the responses here. And then if another question would be like, how would you rate your satisfaction in our effort to reduce stress and burnout? They can answer that in multiple choice format, and you'll get all of your answers here as well. On our champion plan, you do have the ability to choose how often an automatic reminder comes from the tool. So you could say every month, every 3 months, every 6 months, or on a certain date, I want an automatic reminder to come from the tool for them to reassess. On our base plan, on the advocate plan, they set that reminder frequency. So it could be every month, every 60 days. It could be every year. It could be never. So they set that on that end if you do not have the champion plan. And then on our invitation side, we have email templates that have all the language and videos and all the things that would be helpful to kind of get started. There is no limit on how many admins that you can have on the account. So anyone you wanted to add, you could just do invite new administrator and send them a quick email that will get them to a sign up page. So obviously this is a lot of information that we went over in a short amount of time. So I want to make sure that I pause here for a few minutes and take any questions that we have right now.
Great, thanks so much, Sunny. The first question that was asked, is this tool validated, and do we have access to those validation articles?
Yeah, absolutely. This is a validated, fully validated tool. The validation articles are actually published right on our website. So if you go to website.com, index, you're going to see all of the research and validation articles. If you just scroll down a little bit, right here. So you have access to all of those there.
Perfect. Thank you so much. Do we have the ability to add additional questions to the survey?
So you have the ability to add 2 process improvement survey questions like we talked about. Those are fully customizable. But in terms of adding actual questions to the 7 or 9 question survey, the answer would be no, because the reason why we kept it to 7 or 9 questions is to prevent assessment burnout, where they're answering 18 to 25 to 180 questions. And so we want to make sure that it's short and has a good user experience. As we mentioned, this is primarily for the healthcare worker to have a good experience and be able to assess honestly and openly.
Great. I'm not seeing any other questions at this time.
Okay.
Again, feel free to ask any questions that you have. This is definitely your time. We want to add as much value as we can. So if you have any unique questions, feel free to let us know and we'll happily answer those.
Awesome. Yeah, we'll keep going. But yeah, please let us bring as much value as possible to you. Use that question and answer box and we'll tackle all those questions. So kind of moving into the plans. So we have 3 plans that are available. The first being a promoter plan, which is free. So essentially the promoter plan, there's no real customization that happens. You fill out a simple form, we give you an invitation code, you send it out to your staff, and they're able to anonymously assess, they're able to create their account so they can track their well-being over time. They can be compared to their peers and to the national benchmarks, and they'll get access to all of our national resources and key publications that are within the tool. From a reporting standpoint, the institution will see how many people have signed up, but that's it. So they're not going to get any of the aggregate de-identified reporting that we saw on the back end. The first plan that starts with the reporting is going to be the advocate plan. So not only are the participants going to be able to do everything we just talked about, create their account, track their well-being over time, now the institution is able to actually put in local resources, custom resources. They have asked 3 additional custom demographic questions to slice and dice the data a little bit. They're able to get access to that dashboard that we saw where the reporting is broken out by a single demographic. So you're going to see the well-being index score by gender or specialty or year since graduation. And then you'll get an assistance in the well-being index participation plan. You'll have a dedicated onboarding specialist. You'll have kind of all the resources and tools needed to really get started with the well-being index. And so the costs associated with that, there's a one-time setup cost of $10,000 that includes the first version, and then an annual license cost of $5,000, which covers up to 5,000 invitations Yes, you can go over the 5,000 invitations. We do it in 5,000 invitation tiers. So if you had 9,000 participants that we wanted to send the invitation to, it would be 10,000 on the advocate plan. Champion plan, we're gonna get everything that's in the advocate plan, but now we're gonna have an enhanced mobile app experience. There's a mobile app that's available on the promoter plan and the advocate plan, but on the champion plan, the mobile app will have your logo, your branding, your colors to feel like they're in the right spot, one, but then two, that it's your endorsed app. Two, you'll be able to do advanced reports. So now on advanced reports is a feature where we can actually combine demographics to find out who is our most distressed group. So if I wanted to see men who are pediatric surgeons, who have been out of medical school for 5 years, who are in the Phoenix location, I can run that specific report and understand, okay, how is that group doing from their well-being perspective, and what kind of interventions should I be targeting towards that group. Then you also have the ability to do process improvement survey questions. So getting actual anonymous, honest feedback from the participants of the Wellbeing Index on how you can improve processes or how you can really help them improve their well-being from their perspective. And then you also get the reminder management. So you can say, I want to send out automatic reminders every 3 months for my staff to reassess so that we can track our progress on how our interventions or how our processes are improving or not improving from the tool. So the setup cost is the same as $10,000 for the first version. And the annual license cost is $10,000 for up to 5,000 invitations. Of course, if you want to go above that, like in the other example, if you had 9,000 invitations we wanted to send out, it would be $20,000, and that would cover you for up to 10,000 invitations. We do have an amazing pricing calculator as well, right on our website, that you can build out a full quote, and everything is published from a pricing standpoint. We don't have any secrets. We're not hiding anything. So go ahead and check this out. You can say, I want to look at the advocate plan, looking at physicians. You can put in how many physicians you have, and it'll give you an actual breakdown of the pricing and a quote that you can email to yourself or download as well. It's a very simple and easy process from that side. So like I mentioned, 6 versions available, right? So I know we focused heavily on physicians today, but we do have a resident fellow, medical student, employee, nurse, and then an APP version, which is our NP or PA version as well. All validated, all have national benchmarks, all have specific resources to those job roles or to those students. And so that's why they're separate on each of the versions there. A common question we always get is, who is using the Wellbeing Index? This list is by no means complete, as we've just recently started seeking permission to use actual organization names for marketing purposes. In fact, in the last 90 days, we have licensed and implemented the tool to over 20 new organizations, and many more have signed up under our free promoter plan. Right now, we are at close to 600 institutions that are currently using the Wellbeing Index, and that includes institutions in not only the US, but Canada, Europe, and Australia and New Zealand as well, as we continually keep growing the network here. Well, with that, I want to make sure I leave some time to answer questions that you may have about the tool, about the processes, about pricing, about whatever you might have for sure that you might have questions on. And please, there's no silly questions. The question that you're thinking about, others are also thinking about. So please feel free to use that Q&A box.
Thanks, Sunny. Yeah, we have another question. What category, if any, would an admin assistant or someone from dietary use to assess their well-being?
Great question. So the admin assistants and from dietary to finance or billing will all use the healthcare staff or the healthcare employee version of the Wellbeing Index, and all of the resources and benchmarks are tailored to those specific job roles.
All right, another question. Do we have any other versions that are in the works, or any other versions that are going to be specifically validated for any other roles?
Yeah, currently we're in the process of validating the pharmacy version. So that's to be pharmacists, pharm students, and pharm techs. We're probably about 18 months away from releasing it to the public, but we partnered with APHA, or the American Pharmacists Association, to start that validation process and get the surveys out. And we've seen a huge amount of traction. We're over 3,000 surveys in already. And so now we're just starting the validation process and research process to establish national benchmarks and get some of the resources populated. And that should be ready in about 18 months. The other one that we're looking at right now is graduate graduate education. So other graduate type of degrees. So research scientists and occupational therapists. So we're working through kind of like that process and identifying the right partners to help us get to there. But then we're always open to other ideas as well. If there's other avenues or other job roles that there's a huge or a large need in the community, then we're happy to look at other ones as well.
Great. So we have a little bit of a specific question on the pricing, if you could go back.
Yep.
So with the pricing, there's really two different sections. So one is the one-time setup fee, and the second piece is the annual license. So his question is the price per targeted audience, 10,000 for physicians, 10,000 for nurses, 10,000 for employees, or is it 10,000 for all options? And there's really two pieces there. So Sunny, I'll let you kind of tell them what the difference is between the setup and license fee.
Yeah, great question. So for the setup fee, we'll start there. So the 10,000 includes one version, and it's like the overall account setup, just getting you all up and running. If we wanted to add, let's say, a nurse version, an APP version, or a resident version, it's just 5,000 for each additional version. So if we wanted to add physicians, nurses, and residents, it would be 10,000 for the physicians and the actual setup, 5,000 for the nurses, and 5,000 for the residents, for a $20,000 one-time setup fee. You don't pay that again. Now, for the annual license fee, that covers all of the versions that you have. So if we, in that same example, if we had 2,000 physicians and 1,000 nurses and 1,000 resident and fellows, your annual license fee would be 10,000 on the champion plan or 5,000 on the advocate plan, because you're under 5,000 invitations across all of the versions. It's not based on, you don't pay a separate license for the physician version and for the nurse version and for the resident fellow version. You have one account, one license that covers all of the versions.
Great. Thank you, Sunny, for that explanation. Hopefully that answered your question. If you had a follow-up question on that, feel free to ask. Next question we have, so who owns the data, and would you be publishing with our institution's data in the future, and how does that process work?
Great question. Yep. So we own the data as a third party, and we give a license for you to have access to the data as part of the agreement that we have with you. We do not, as part of our agreement with you, we don't share that data with anyone, and we don't, sell that data or do anything else with it, except that we house it here to make sure that the physicians and the nurses and the staff feel safe and comfortable that it's not the institution that's going to have access to individual data reports.
And the only other addition to that is the only other party that would have access to the data would be Mayo Clinic for research purposes in anonymous aggregate format, and would not be singled out per institution. It would be all data in aggregate.
Right. It wouldn't say like this particular score comes from Yale. No, it'd just be an aggregate information of physicians nationally are looking like this.
Mm-hmm. Any other questions that anyone has? We'll happily stay on and continue to answer your questions. Well, it does not look like we have any other questions at this time.
Well, hey, I mean, you guys might not want to ask your questions right today. You might come up with other questions later. So please take down my information, and we'll be sending that information out as well with the recording. Anytime you have a question, give me a call, send me an email, and we're happy to kind of tackle those questions as well on an individual basis. But thank you guys again for joining. Like I said, it's very encouraging to see so many people interested in well-being for the institutions that you guys are working with. It's not an easy topic to always talk about, and it's very important to prevent the next tragedy and to get ahead of things. So once again, thank you so much for your time today. Feel free to, like I said, reach out if you want to grab a meeting, if you want me to go through another demo, if you want me to answer any questions specific to your institution. Happy to do that.